Together, we will see the main points of the ERA-EDTA guidelines on vascular access treatment. And first of all, what about the treatments for promoting fistula maturation? Giving antiplatelet agents like aspirin, diclofenac, or clopidogrel, which actually promote, reduce thrombotic events, must be balanced against uncertain effects on maturation and bleeding. The same is also true for perioperative heparin, which increase fistula patency at 1 month, but has increase in bleeding complications. Far infrared therapy applied in the first 3 months reduces thrombotic events, but again has uncertain effects on maturation. This does not mean that when you don't have thrombotic events, you will have necessarily a matured fistula. And depending on other antiplatelet agents and other agents like fish oils and statins, we do not have enough evidence to go forward. Regional block anesthesia is the choice over anesthesia because it produces increased blood flow. But the evidence to support an end of vein to side of artery over side of vein to side of artery anastomosis are inconclusive. Moreover, there are insufficient evidence to support open or endovascular interventions, and the decisions should be based on local expertise. And there are many interventions that have been deployed, like for different kinds of problems, as balloon angioplasty for stenosis in draining vein or anastomotic region, or in arterial flow. Moreover, there are balloon angioplasty plus coiling of the accessory vein with or without stent deployment. Concerning surgical interventions, actually there is only proximal neoanastomosis with or without accessory vein ligation, treating stenosis in juxta-anastomotic region. Both of them, both endovascular and surgical interventions, have modest 1-year secondary patency rates. And of course, radiological endovascular, the spectrum of endovascular intervention is broader than surgical interventions, but at the end, the effectiveness, especially for correction of stenosis in juxta-anastomotic region with anastomosis, is superb. Moreover, for a standardized exercise program that concerns both hand and arm exercises may improve fistula maturation, but there are no evidence for a specific exercise program. As for perioperative prophylactic antibiotics, these should be given before graft insertion and before any complex arteriovenous access procedures. And these procedures are all procedures except of native radiocephalic or native brachiocephalic fistulas. Okay, let's go on. As for maintaining long-term fistula access patency, fish oil given at the year after fistula creation actually increases patency at 1 year, but has an unknown effect on bleeding risk and other side effects. The same is also true for far infrared therapy, and there are quite a few randomized controlled trials to support these results. As for other factors like antiplatelet agents or statins or vitamin D, there are inconclusive evidence to support their administration. For maintaining long-term graft patency, we should not use warfarin in combination with antiplatelet agents, and of course we should not use clopidogrel in combination with high-dose aspirin because we increase the bleeding complication. On the other hand, fish oil has shown an improvement in graft patency at 1 year, but again, it has an unknown risk for bleeding. Concerning other factors, antiplatelet agents, warfarin, statins, there are inconclusive evidence to support their administration. Clinical monitoring is the cornerstone of surveillance, and we should rely on clinical monitoring and not on technical surveillance, especially for graft surveillance, and there are inconclusive evidence as for fistula surveillance. The timing of intervention concerning graft thrombosis is generally not considered an emergency. Nevertheless, a timely attempt to declot a graft should be made. On the other hand, fistula thrombosis is actually an emergency, and a declotting attempt should be made as soon as possible. Even if this is not possible, thrombosed fistula should be declotted even after a delay of days or weeks. Concerning surgical or endovascular intervention, one have to have in mind that imaging of the inflow and the outflow is of the utmost importance, and the final choice between surgical and endovascular interventions should be defined and based on local expertise. Thank you very much.